Hello to everybody. I'm here with Massimo Chessa and Mohammed on my right side. We have a patient on the table with a PDA. And very briefly, Francesca Pluchinotta will introduce you the case. Please, Francesca, go ahead and introduce the case.
Yes. Next, please. So the patient is a female, 6 years old, body weight 16 kilos, height 110 centimeters. She has been diagnosed in infancy with a patent ductus arteriosus. In the last year, she had delayed growth and frequent respiratory infections. On physical examination, we noticed a continuous murmur on 3 out of 6 at the left sternal upper border, and the HEG is a normal sinus rhythm with the mild sign of left ventricular hypertrophy. Next, please. Next slide. Chest X-ray show an increased pulmonary blood flow. Next, please. So echocardiography show a large PDA with high velocity left to right shunt. On the 2 images on the bottom, you can see on the left a enlarged left ventricle, but with a good systolic function, and on the right you can see on a short axis view the large PDA. Next, please. This is another view of the PDA. This is an arch taken from a subcostal view, and you can see like the ductal ampulla. Next, please. What we do today, we intend to close the PDA percutaneously.
Okay, thank you, Francesca. Carlos, well, this is straightforward, at least medium-sized PDA. Usually, it's very difficult from echocardiographic findings to identify the precise morphology and size of the duct. You may agree with that. Hello?
Yes, I do. Yes.
And we did some. Yeah, we catheterized with right femoral vein and femoral artery with 5 French sheath. We did some angiogram that I'm going to show you. Can you have the pictures? You see the pretty large shunt through a PDA that looks like a slightly elongated or tubular duct, yes?
Yes, it is.
Well, just to identify better the morphology, we did as well a RAO angiogram, as you see here. It's probably will allow to see a bit better the morphology. That's an elongated ampulla with pretty large shunt. We did some measurements as well. Well, we crossed the duct very easily from the right side. This is a 6 French catheter from the venous side to descending aorta. And you see, in spite of the catheter inside the duct, injecting the aorta, you see a pretty good amount of shunt in spite of the catheter through the duct. Yeah. We made some measurements here. The minimum size of the duct, well, this is the length, approximately 5 millimeters. The minimum size is, well, let's say 2.2 in this projection, and in another projection you measure 2.8. And taking into account that with the catheter inside, there is a residual large shunt, I suspect that the minimum size of the duct is at least 3 millimeters, with a long ampulla, approximately 7-8 millimeters, and the size of the ampulla between 5 and 6 millimeters. So these are the findings, and I would like to know your questions or comments and the way you would suggest to close this duct. Hello, Carlos?
Yes, yes.
I cannot.
We were checking. We were talking in the panel on the side, on the age of the patient. So it's It's a 6 years old.
Yes, correct.
So what device are you going to use?
Well, I would like to know your suggestions, Carlos. Well, I think we have several options.
Do you want me?
Yeah, to make me in trouble, Carlos.
That's why I don't want to answer.
Well, I think there are a couple of options here. We can use traditional ADO1 from the Venus side, probably 6.4 ADO1, or we can also use ADO2 additional size, putting into the ampulla, probably with the ADO2 AS with the central waist of 4 millimeters. What do you think?
You think that the length of the ADO2 will not protrude too much onto the pulmonary artery if you put the disc onto the ampulla?
Well, pretending we are going to use ADO2 AS, I think the central waist, in my opinion, should be, hopefully, sitting exactly in the ampulla. What do you think?
I agree.
So what do you prefer us to use? ADO1 or ADO2 AS?
Let me ask Elhanan is here on the what would you do, Elhanan?
I use ADO2, not ADO2 AS, because you've got a nice ampule, so I don't see any reason why you just wouldn't put like a 5.4 in there. I don't see why you want to use an ADO AS, that's all.
Shaq?
I was just going to disagree with Elkanon and say ADO1, there's a good ampulla there, and so you'd get an excellent result with ADO1.
So excellent. A third comment will be ADO2 AS.
You will get a good results also with the coil.
With coil?
Yeah,
Well,
you might have to put more than one coil in order to get rid of any possibility of hemolysis.
yeah,
But
I don't
so
think...
you want to finish up with a single device.
I wouldn't put a coil, but...
Well, I think...
That's probably because in US you have coils only.
almost.
Well, I think that for using coils, this is a pretty large duct. I would not be comfortable to put a coil in this such a large duct. But if you... Can we go back and see the RAO angiogram? The last angiogram we did, the RAO. You see here? That's a pretty good ampulla, pretending that, well, the minimum size is approximately 3 millimeters at least. I think that a traditional ADO1 will fit into the ampulla nicely, as
Yes.
who suggested it? Shaq? Or Carlos?
Never. I would use an ADO1 because, as Shaq says, I have no choice, either an ADO1 or a coil. Actually, no, we have now the ADO2.
Carlos.
Yes.
Yeah, Mario, it's John Cheatham.
Yes,
although
John.
we are a third world country, a third world country, this ductus is designed for, if you didn't have an ADO2, ADO2 AS, AVP2 or anything, this was designed for the ADO1. This is the exact morphology. So why wouldn't we just put the device that was designed for?
Yeah, it's a rather long ampulla with conical shape, a bit more elongated than we usually see, but I think that ADO1 will sit in this kind of dot very nicely. I agree with that. And John,
Mario?
what size would you use, pretending we want to use an ADO1?
A 5, a 6, a 6.4.
A 6.4, yeah.
I would use an 8.6, Mario.
8.6 is probably too big, unnecessarily too big, Chuck. What do you think?
I was just trying to be different from John Cheetham, but
Oh, I see.
that was the only reason, yes.
Well, I think that our first choice here will be to use a AD01 6.4. Yeah? We will introduce through the venous side, we will check the aortogram, and we will see how it looks like. Okay? Okay. Any other comments or questions?
Any comments from the audience? No questions, Mario. Go ahead.
Okay, so in a second we will show you the device, but probably you're all familiar with this device. Okay. Can you show the table here? This is the introducer set, a 6 French introducer. Okay. Can you have the device? Flush. Non preparo al massimo qua, per favore. Facciamo qua. I think there is no need to show you the AD01, but just in case, can you zoom on that? Zoom more. Okay. Okay. So this, the morphology is likely to conform with this ampulle or this duct. Yes? Okay. So now we will load this well, I'm a bit surprised that I could put the wire and screw the device without wearing the glasses. I'm very surprised about that. Okay, we load it into water. Okay, this is what is going to happen on the duct when extruding. This is going to be like this. Yeah? Okay. Happy with that?
Very good.
Okay, so let's go with the introducer. Questo è... Andiamo a togliere questo, vero? Let's go to AP, please. Okay, we don't need to see our hands. It's not very interesting. Let's see the fluoro.
What wire do you have across?
This is an exchange wire. That's an extra stiff wire. We can use a normal, ordinary exchange wire. Probably a rather stiff wire. Okay. So we'll see the fluoro now, yeah? I retract the pigtail for a second. The Malin sheet is getting across the dot very, very easily. Now we can take the wire out. Okay, now we are ready to introduce the... Yeah, Carlos, what would you like to use? What would you prefer to use in this case? The lateral, RAO?
I prefer, personally, I like the lateral view.
All right. Me too, in spite of the fact that in this case, probably the dot was best seen on RAO, but we will see. Let's get started with lateral and then we may change, okay?
On the lateral, you may need to go slightly caudal.
Yeah.
To visualize it better, but it.
We will see.
Get.
Well, before inserting the device, we can also do another angio here. No. You say French. Let's do an angio just to see with the sheath across how the dot looks like. Go. Okay. So the sheath is not occluding the. Can you stop have a steel frame here? All right. Okay, can you see the fluoro extruding the disc in the aorta, pulling the sheath back, doing a test here. Okay. You see, because of the tension, the sheath and the wire is taking back downwards the dot. But I think that when deploying the rest of the device, it will adjust itself. I'll do it on scene. Let's do another angio here.
One thing that I've done in cases like that is not using the release cable, and I know St. Jude may not like that, not using that release cable, but using the release cable of AVP2s.
Yeah, which is a bit softer and delicate, yes?
Much softer,
right.
And it adapts better into the angulation.
Yeah, let's see whether deploying the rest of the device, what will happen. Okay, so let's do another angiogram here. What do you think? I think the device is sit exactly in the pool. Look, yeah, it's not very nice to see, but it's probably effective, isn't it?
Mario, it's not flared at the pulmonary artery end, is it? Unless you think that's because of the tension.
That's what I think, Shaq, that for cases like that, that is in that size, and
you
for
see,
that
I'm pulling.
I'd rather use the very flexible wire cable that comes with the AVP2s that you can mount.
Yeah, but well, you see.
At the moment, there's.
Go on, Mario. Yeah. It's a funny orientation of the device attached to the wire, but the device is there. I'm pulling now, and apparently it's sitting nicely, isn't it? Let's do another angiogram while I'm pulling the wire.
Mario, Joe Giovanni here.
Yes.
I think the problem is that it's nothing to do with the wire. I think the screw mechanism on the device is not normal, and I've seen this deformity in a few patients.
Yes.
And it prevents the device from opening properly proximally.
Yeah.
So I think it's to do with the attachments rather than with the cable.
Yeah, that's right. But anyway, the device looks in the right position to me. What do you think?
It looks right position, but there's a lot of flow around it as well. So it's because it hasn't caused that flaring.
Yeah, but what would you suggest? Release the device or do something else?
Well, I would be uncomfortable about releasing this at the moment.
I agree.
So what would you do?
So either you
Rivediamo.
redo this, or
John Bass has another question. John?
or upsize.
Excuse me, Jack.
Upsize.
Mario, this is John Bass. I just think maybe the reason the plug on this device has not expanded is because the length of the ductus is too great. It may fully expand when you release it, but the plug on the 8.6 device may be a little bit longer. And I think there's plenty of room to get it in.
That has to do with the cable. The cable is too stiff. That cable is too stiff.
Well, but I don't think this is a problem of the cable. I think the problem here is the length of the...
Mario, Kevin here. I think you should just take it out and put an 8.6 or even a 10.8.
Well, as you see...
It'll take 2 minutes.
You would suggest to use a larger device, yes?
Yeah.
And I think so, because, well, we have two problems here, in my opinion. One is because the length of the ampulla is a bit more than we would like to have. And another point is that the tissue is very distensible, a stiff wire, and un 7.
Mario, you've dilated the duct. You might need a 10.8 now.
Anyway, I'm not happy as well about this, so I would like to do another angio here and see whether... Ragazzi, aiutatemi. It's very distensible, so the initial size probably are different. Let's do another angio here. Well, not much difference, isn't it?
Yes, please. Hello? Yes. Can we have the microphone here in the front, please?
Hello? Yes, Mario. This is Francisco Garay from Chile.
Yes.
Just to be a little provocative, I have to say that we have been closing this kind of elongated ductus with a vascular plug 2, with the AVP2 for this kind of elongated ductus.
Yeah, it's elongated. It's elongated, so that's why a possibility here, in spite of the advice we took from most of you, to use an Amplatzer AD01, we could go ahead and use an AD02 here, or an AD02 AS, long enough to sit in there. Why not?
Francisco is talking about the AVP2, the vascular plug 2, not the Amplatzer ductal occluder, but the vascular plug, the 3-segmented device.
Well, I think because the problem with the elongated ductus is that any device with a retention disc will be a weird configuration inside of the ampulla. So this kind of elongated could be closed with a 6 or 8 millimeter AVP2.
Go ahead, Mario.
Yeah, but AVP2 is very similar to Amplatzer vascular plug. Not very different.
It is a vascular plug. It is the vascular plug 2 that has one disc, one segment, and one disc. So basically, it is cylindrical because the disc and the cylinder in the middle are all the same diameter, but it is the wires that make the AVP2s are very, very soft compared to the ADOs, and it will adapt better to the configuration of that ductus.
Can you see again the last angiogram we did here? You see it's elongated. Well, actually, we measure this length approximately 7-8 millimeters. And I will try to use an ADO2 AS, 6 millimeter long. No, no. Longer than this. You see there are many. I would, well, no. 5, 6. Well, another point is sometimes it's rather unpredictable to see the morphology of the duct where catheters, wire are inside. So it can modify a bit the morphology of the duct. Yeah? Okay, why don't we make a try here, just for educational purposes, I think is nice. The largest ADO2AS is 5.
What size are you going to use?
Yeah, the largest ADO2AS is 5, yeah? And the length I'm going to use is 6 millimeters. So let's try.
I wouldn't bother, Mario.
Yeah?
I wouldn't bother. It's just going to pull through.
Thank
you. You think it's too small for this duct, Joe?
I think so. I think so. Because you had a 6.4 with a large shunt. And I think it's just going to pull through. But you can try it. I did that exercise last week.
Yeah.
And a 2-kilo baby, and yeah, I'm pretty sure that's what will happen.
And what was the result?
I feel the same way, Mario. I think the 5 is too small for this ductus.
The 5 is too small is quite possible, yes. Let's see the angiogram again. This is a 6 French. This is a 6 French introducer. Well, I don't know. I'm not sure. Could you let me give a try?
Sure. It's not.
Okay.
It's not hard to pull it out if you don't like it.
Yes. If you're not happy, we will just retrieve it. Okay.
Mario, the duct is changing its size, isn't it? Depending on whether there's a sheath there or whether there's a device there. When you had the device in, it looked much bigger. So you don't know whether that's sort of spasm related or what. So,
well, I really don't.
You think that the 6-year-old can still have a spasm?
I don't think that there is a spasm here. It's a problem on morphology.
The diameter, this is an expansile duct. The ADO2AS is really, like Joe said.
So you're doing a daughter effect, not a spasm.
Hmm.
Well, can you see the table now? So this, can you see, can you zoom here? This is 5 millimeters and 6 millimeters length. Let's see whether.
So Mario, this is very similar to the AVP2.
Yes.
With the difference that this only goes to 5 millimeters, and the AVP2 you could easily put a 6, 7, 8 millimeter that will adapt and wedge well into the ducters. That's why we were suggesting that an AVP2 may be a better choice with a slightly larger. You're limited here with a 5 millimeter diameter.
Yeah, you may be right. Let's see what's going on using this plug. Can you see the fluoro now? Fluoro, please. Okay. Okay, you may see the distal disc.
Yes, we see it.
Yeah.
Yes.
Let's do a quick angio here. Sveglia. Okay. Right. I'll try to keep the position here and deploy the rest of the device right there. Okay. Let's do an angel here. Still a lot of flow across. Yeah.
So Mario, is the duct bigger because there's a plug there, or because it's changing shape on its own?
Well, I don't know. However, I see too much flow around it, and actually it slips through very, very easily. Yeah.
And that's what Joe said would happen.
Yeah, that's right. So this attempt failed, obviously, wire. And so probably an ADO1 larger size will be okay. What do you think?
I think it's a good choice. An ADO1.
Larger size.
What size are you talking about? An 810?
What's wrong with an 8.6?
We've been using a.
You have a complex of inferiority, Chair?
Mario.
Yeah.
Mario. Yeah, in the United States, we would use the ADO1 LS. Larger size.
Hang on, John. I'm just going to ask John Cheetham, would he put a covered stent in this duct?
It's rather easy to go there, isn't it? You see how easy it is to advance. This is a 7 French. Okay, I need an exchange wire here.
Joachim? Mario, this is Joachim.
Hi, Joachim.
I think, honestly, part of the problem with your first device, maybe you didn't pull it enough. I don't think it was well expanded, the pulmonary end of your device. So whatever you do now, I think 8.6 is a good choice. But I remind you to do an angio on the RAO view, just to be sure that the device is not simply squeezed inside the pulmonary end of the ductus, which I think was the case partly with the first device.
Yeah, maybe, but
so you'll need to pull. I think you'll need to pull a little stronger on your disc, so you put it, you push it. You wedge it much better inside the minimal diameter of your.
Well, actually, I'm be fully strongly, Joachim, and I think that the problem was just the length of the dot, or the ampulla, if you like, and the size itself. Why don't you try to just use a larger ADO1 device, maybe attaching it, as Carlos suggested, to a softer wire, yeah? Like the wire we'll be using for the unplastered duct additional size.
Mario, you had no problem with the wire. I think the problem is with the size.
Yeah, I think it's not a problem with the wire as well. Yes, that's right. I mean, it's just a matter of the morphology and the size, which is borderline between 6.4, 8.6. So why don't you give me an 8.6 ADO1 and load it and see what's going on.
Just a point about the wires. The wire for the ADO2AS is not compatible with the other unplastered devices.
Dammi
the AVP2 wire, it is compatible with all the devices.
That's what I said. I said the
right.
ADO2AS is the only wire.
There is the only wire that is not.
Yeah.
But the AVP2, the advantage is, and I beg to disagree with the cable has nothing
Why
to
don't
do.
you
I
see
think
the
it has
table?
a lot to do with the angulation. And that angulation, you are forcing with the wire, with that cable, you are forcing the device.
Let's see the table.
Where you have that cable that is very thin.
Let's see the table.
For the AVP2, it adapts to the anatomy rather than following the strength of the cable release.
Yeah. I think the point I wanted to make is just in case he's got the wire for the ADO2AS out and he wants to use it, it's not compatible. Yeah.
Massimo is loading the device on the table. Can you see that? No.
Can we see it?
Massimo, show them the device.
You're using a 8.6?
Yes, 8.6. What? Massimo? Aiutami Massimo, per favore. Let's see fluoroscopy now, please. Okay. All right. I'm advancing the device through the sheath. Here we go. Pull the system back. Release the disc in the aorta. Can you do a quick angio here? You're far in the aorta here. Pulling more. Do another angio. Still the angulation is rather odd, but it's more promising. Yeah? Okay, let's do another angio here.
Now it looks good.
It looks much better, isn't it? There is still some flow around the device, but I think this is the correct size for this duct, isn't it?
It definitely looks better because now it's squeezed. Can you do an RVO angio, please?
Yeah, that's what I'm doing, exactly. And see how it looks like in RAO, which probably is depicting the morphology better. I don't know. Okay. Let's do an angio here. Go. Yeah, I think the device is sitting more properly in the duct ampulla. Yeah? Lateral. What do you think? I'm happy enough with the position and the size of the device and how it looks like, and I think I'm going to release it. Yeah?
Looks very good, Mario. Yep.
Okay, I'm going to release it in Cine so you can see that better. Right, device is released, still there. Okay, Let's do another angio here. Well, there is still flow across it, but I think that the device is well expanded. Well, you may see, at least in my opinion, interestingly enough, as opposed to more conventional ducts, the more distal on the pulmonary end part of the device is larger than in the middle. That's what the cause is because of the tubular morphology of this duct. Do you agree with that?
Yes, it's squeezing the middle of the stem.
Exactly, and expanding towards the pulmonary artery.
Yes.
But I think the distal disc in the aorta is large enough to guarantee the stability of the device, I think.
I don't think this device is going to go anywhere.
Yeah. Well,
looks very good, Mario.
It's not surprising that we still have some flow across it. Maybe we do another angio here, but I'm confident that the residual flow will decrease and disappear probably in 24 hours, as usually happens with this duct. Okay, let's do the last angio here. Okay. I think this is probably the best compromise of the device type and device size for this rather, I would say, a bit complex morphology of this duct. Are you happy with that?
We are very happy with this. I think it's the best you can do. If you would have used a larger device, I think you would have more problems in the middle of the aorta. I think that's the right compromise, as you said.
Yeah, that's right.
Congratulations. Very good job.
Yeah, thank you very much. Okay. Bye-bye. I see you tomorrow. Okay. Bye. Have a nice day.
Bye-bye. Thank you.
Bye-bye.